Welcome to the MS&Me Radio Network, a division of the Multiple Sclerosis Global Support Network. The following program broadcast is an original creation by the broadcast entity. Discussion within the following broadcast should be used for informational purposes only and is not a substitute for professional medical advice or consultation. Before considering application of any broadcast content in the following program, please consult your healthcare provider. If you feel you are having a medical emergency, please contact your local health services for immediate assistance. MS&Me Media and the Multiple Sclerosis Global Support Network do not guarantee or warrant the accuracy of information in the broadcast to follow. The Multiple Sclerosis Global Support Network provisions broadcast services to program hosts. Information discussed in the broadcast does not necessarily reflect the views, opinions, or goals of the network and are solely those of the show broadcast host. Should you wish to host a broadcast, please visit our website at msmemedia.com and submit a request to become a program host. We thank you for listening to the MS&Me Radio Network. Enjoy the show. Get ready for Ask MS&Me. Have an MS-related question you want answered by your fellow MSers? Use hashtag AskMSME on any of your social media accounts, and we'll get as many answered as possible. Get ready. Here comes Ask MS&Me.
Sure do. Let's see here. We have our first question comes out of our Info Hub group.
Okay.
I'm wondering what anyone who has vertigo all the time can take to help, even just a little bit. Dr. Nicholson, can you explain to the audience what MS vertigo is and maybe help them without some things they can do to help?
Sure. So vertigo is when somebody feels like the room is spinning or there's some type of movement sensation. And so there are a lot of different causes of this. Many people with MS can have vertigo where they feel like things are spinning or there's some type of motion in their head or around them if they've had lesions or damage in the brain stem or areas that affect those pathways. And so it can be a real challenge. And what I'll tell you is that most of the medications to help this really kind of stink. I think that we could do a lot better. So that's just being straight out honest. One of the things that I've found has provided the greatest benefit, and I know it's not an easy answer because obviously we'd like to say, here's a pill, you take it, you fix it. But nobody's come up with that yet. And so really, if somebody's having that central vertigo from MS, getting in with a neuro specialized vestibular therapist, so we say the inner ear is the vestibule, so it's vestibular therapy, that can help quite a bit to retrain the brain and the eyes and help to improve how you feel. And it won't be comfortable at first when you do it, but doing the exercises that they teach you can be incredibly helpful over time. I will say that some individuals who have severe vertigo may benefit from intermittently taking a medication called meclizine or Antivert. That sometimes can help, but for a lot of people, it may just only help for a brief period of time. Also, if somebody's having severe vertigo, sometimes using a brief course of a class of medications called benzodiazepines or medications like lorazepam or Valium even can help. But the real downside of those medications is we don't really want somebody on those long term because they cause you to be very tired and very sleepy. And so that's why I admit to you that there are not a lot of great medications. Now, the other important thing is to know that it's not just MS that can cause vertigo. So one of the more common reasons that I see vertigo in my patients is because they've developed something called benign positional paroxysmal vertigo, and we call that BPPV, which I know is very confusing. But that means that, all of us, we have fluid in our inner ears, And we have these crystals called otoliths that float within that fluid. And that helps us to know where our body is in space when we're standing up or sitting down. But sometimes those crystals can get stuck. And when they get stuck, we can feel that things are really spinning. And the most common sign of this is that when you move or change position or move your head, that's when it occurs, and it's really intense and severe. And it usually lasts for, minutes. And then if you keep your head still, it really shouldn't happen again. And that's something that there are specific maneuvers. There's something called the Dix-Hall pike maneuver that can be done to try to reposition those crystals and help to prevent you from having that problem. So I'd say the strongest thing that we have to fight dizziness is actually doing some vestibular therapy with specialized therapists. And then if somebody's having, kind of a new onset or really severe onset, using some of those medications I mentioned temporarily can really help. But I think it's really important that if you're having it and it's a new symptom, to check in with your doctor so they can make sure to sort out what the issue is. Because if it's a new lesion from your MS, then that's really something concerning, and we want to make sure you're on the right treatment. And, maybe giving you steroids could improve that if it had just happened, if it's from MS versus if it's from a peripheral issue.
Yeah, that's a great information. Let's see if we have another one coming in off of social media. We have one coming in off of our Facebook Ladies Only group. It says, has anyone had trigger thumb or trigger finger? Is it related to our MS? I've been reading, and it sounds like I've seen a lot of people with MS have it. I'm familiar with it just because it's happened in my family, even the surgery for it. Trigger finger in general occurs when the tendon in your affected finger becomes inflamed. And then the people that are most at risk for this include women, people with diabetes, arthritis, people whose regular activities strain their hands, including their career. Symptoms include your stiffness, popping, clicking sensation, tenderness in your affected finger. Triggering's usually worse in the morning when you get up, much like many of our symptoms. Treatment includes splinting, medications, surgery. My mom had surgery on 2 of her fingers. Patients with MS have an association with Ehlers-Danlos syndrome, EDS. I have EDS. I know my mom and several of my family members do as well. It's genetic. But EDS is a group of connective tissue disorders caused by a defect in the synthesis of our collagen, type 1 or type 3. In the following studies that I'm going to read to you here, let me find it. I know I pulled it up on my Google. It's published in Multiple Sclerosis. The researchers found a 10 to 11 time increase in the prevalence of EDS in MS patients. The researchers concluded that the association may be due to a possible causal relationship with on a connective tissue level. Recent evidence, that we were able to find suggested that a defect in type B collagen synthesis is causally linked to a classic type of EDS. Our type 1 collagen is the most abundant of total body collagen and is found in fibrous connective tissue such as our tendons. But a type 5 collagen can stabilize type 1 collagen by co-assembling with it. So defects in the type 5 collagen synthesis produces this grossly deformed collagen fibrils. So electron microscopy studies of the collagen in EDS have detected abnormally thickened type 1 fibrils associated with a high degree of variability in the width and shape, and as well as the spiral fragments. So tissues cannot withstand even normal stresses in patients with collagen diseases. So patients with EDS thus are more prone to developing that tendon injury. And then they connected the high prevalence of EDS back to MS. So it was kind of a connect, and I'm sure Dr. Nicholas can speak more on that. It wasn't a direct link, of course.
Absolutely. So, everything you mentioned is absolutely correct. And there's no correlation really in terms of MS disease activity and causing a trigger finger. But I think what you've already said has really explained why that can happen. And so I think the bottom line is that if you have or you suspect that you have trigger finger, getting that checked out by your primary care doctor, and then they can actually evaluate what needs to be done. You may need to get some type of steroid injection. Sometimes that can help. And then also there are surgical procedures that can be done to help release the tendon and have the problem resolve. And so I'll tell you that as somebody who sees MS patients every day, and in our center we take care of 4,000 patients, it's an incredibly rare thing to be seen in MS.
Yep. Yeah, it is. Now, if you're going through this, if the one who asked the question is still listening, one thing I will suggest, if you do have to go to the surgical option, God forbid, for the trigger finger, I know with my mother, because she had 2 separate operations, the therapy afterwards is key to a good result. So go to the prescribed therapy, be very diligent with your home exercises, and you will get a better result with that, just from my own personal experience. So I wanted to add that. Now let's see if we have anything else coming in. We do have one online off of our singles group. It says, have the early indications shown that the Ocrevus has slowed or stopped progression? Well, I mean, I think Dr. Nicholas could definitely speak to this better than I could, since she was involved in the studies and the treatment every day of patients who are being treated with that DMD.
So absolutely, the results have been incredibly exciting. So the clinical trials that were done in both relapsing or remitting MS and primary progressive MS were highly significant in terms of what we looked at. And so in relapsing or remitting MS, the primary outcome was looking at reduction in relapses or annualized relapse rate, and that was significantly reduced as compared to standard of care being an interferon treatment for relapsing or remitting MS. And so this medicine has definitely proven itself in terms of preventing new disease activity on MRI and preventing new attacks. It's on the range of reduction in new relapses of about 85 to 90%. And then when we look at primary progressive MS, it was significant in terms of its reduction in progression and disability accumulation. And so it's very exciting because nothing else that we've ever studied before has shown that benefit. And so the evidence is very, very clear. It's very, very impressive, and we're just very excited about it. And I think that the most exciting thing is that we finally have a disease-modifying therapy that's shown benefit in primary progressive MS, which we've needed forever. And so my hope is that now that we see this mechanism and how well it works, that we're going to see so many more treatments come about for primary progressive MS.
Yeah, I'm very excited about it, and the others coming after it, for SPMS and more for primary progressive MS. And people tell me, they're like, when they read it and they're not familiar with, living long-term with primary progressive MS and the fact we haven't had anything, and they're not that familiar with the rates, on these trials. And I told them it reduced it by 24%. The rate of the progression by 24%. They're like, only 24? I'm like, you don't realize how significant that is. And if you're living with it, you're like, yay,
don't.
24. You're like, yay, 24. And,
exactly. I mean, it's incredible.
It is. It really is. The numbers that have been shown, and I know the first patients that are receiving it, many have reported back to us, in our online groups. And we heard from one today, and she is just thrilled with, her progress so far. So, and she's been all through the trial with it. So she is just very thrilled. So I hope we hear more and more and more of that. And, of course, more medication options to come. All right. Ted, is there another one coming through? Oh, go ahead.
Real quick on that one, one of the things that we found, so the primary progressive MS trial, so it was called Oratorio, and you can easily look that up online, but we found that, 3 times the number of primary progressive MS patients that received Ocrevus actually maintained this new outcome measure that we're looking at no evidence of progression of active disease. And so that's really exciting. And versus, so that was about 30% versus placebo, that was about 9%. And so it is a big difference. And so obviously we're looking for something that is 100%. But I think when you go from nothing to that, that's a big deal.
Mm-hmm. Now, recently, I know in our groups, we started hearing clarification on people asking about SPMS. And they were like, well, we heard that if you have SPMS and you're not having active, disease activity as far as relapses, then this drug is not effective for you. Can you clarify that for them?
So I'm going to say that this is a very much opinionated comment. And you're going to receive different opinions based on the MS specialist that you speak to. But I will tell you that one of the big controversies in MS over the past couple of years has been, are there truly these different disease types? And so the question is primary progressive MS a different pathology from relapsing remitting MS or secondary progressive MS? And that's where Dr. Stephen Krieger has come out with a model of MS called the leaky swimming pool. And basically, this is, described as, when you're very young, the water in your pool, which represents your brain, is very, very high. And so you may have little areas of damage, but none of those areas of damage really go above the surface of the water. And so you don't really have any symptoms, even though that damage is occurring. But for some reason in relapsing remitting MS, we see that people have a lot of symptoms, and symptoms in the setting of an attack where they get a new problem, like, my arm got numb over hours to days and it's been constant and now it's really bothering me and it lasted for months, versus somebody with primary progressive MS that says, I never really had something that I can pinpoint exactly when it came on, but if I look at my life over the past several years, I kind of had this decline where I felt like I was tripping all the time on the rug and I blamed it on my shoe. And then when I got new shoes, it still happened, and then it kind of got worse. And so, with that model, we think that some people may be more likely to have symptoms happen earlier in a setting of attacks versus other people where that damage that occurs in the brain and the spine may not ever result in showing it above the surface, above the level of the water. And so over time, as the brain shrinks, because all of our brains shrink, again, as we talked about, whether we have MS or not, at the age of 20, they start shrinking. And so those symptoms can slowly become obvious over time. And so there's been this big argument now as to whether these are actually truly separate diseases or if they're all one disease. And interestingly, when we look at the natural history of MS, or really what happens in MS when people are not on treatment, the course of secondary progressive MS is identical to primary progressive MS. And you cannot tell the difference in terms of the degree of worsening over time. And so many of us in the field have felt that this may translate very well in terms of looking at therapies that were beneficial in primary progressive MS, but very likely those therapies could also be effective in secondary progressive MS. Now, obviously, Ocrevus was not specifically studied in individuals with secondary progressive MS. But I will say that many of us have considered and used this treatment in individuals with secondary progressive MS because we believe that those two disease courses are very much the same.
Yeah, that was my take on it, but, I've been told by others, no. So, and that's why it wasn't approved. So, but I'm like, I'm kind of leaning the other way. So I think I agree with you, Doctor.
And it wasn't studied in secondary progressive MS.
It wasn't. So, I think we do. We definitely needed a study on that. Now, let's see if there's another one coming in. This one's coming in offline. Yeah, it's right off of Twitter. It says, if we become numb in the vaginal area, will it always be numb? So I'll defer to you because that's actually a higher level question there.
Sure. So, if somebody develops numbness in their pelvic region, that's very commonly from spinal cord disease, from MS. And
Yeah.
so
Yeah.
if it's something that's brand new, and, that would be really concerning for a new attack or a relapse.
Mm-hmm.
And so certainly just like other attacks or relapses in MS, somebody could talk to their doctor and consider receiving steroids or even plasmapheresis to try to speed
Mm-hmm.
up recovery. But we know from research that's been done that if somebody receives steroids or not, that they're going to be better to the same degree in about a year. But if you receive treatment for that attack at the time of the attack, that it can make you better faster. Now, if you've had numbness in your pelvic region and that's been going on for years, it's very unlikely that that's going to just improve on its own. And so, that can be really challenging, especially when we talk about sexual function, because if you don't have any sensation there, then it makes it really hard to have a desire to have sexual intercourse or to feel pleasure from that. There are options out there available for that can help with that. Again, nothing is perfect, but that's a common symptom that my patients have. There was actually a device that was developed for female sexual dysfunction several years ago, and it's called the Eros device. It's spelled EROS. And that's a device that's actually a suction device that fits right over the clitoris and pulls, acts as a suction because it pulls blood into that region. And when you pull increased blood flow into that region, it actually enhances sensation. So I have had a number of patients who have felt that that has really helped them to experience pleasure, even if they've had numbness in that area. And so that's something that used to be a prescription only. It is an FDA-approved device for female sexual dysfunction, but it's something that you don't even need a prescription for, because for one of my patients, we had looked recently, and it's even available on Amazon.
Wow.
But that's something that, if you do have that problem, getting a doctor to write a prescription and seeing if there's any insurance coverage available could be very, very helpful. Also using lubrication, using, other devices. I know it sounds kind of embarrassing or silly to talk about, but using things like vibrators, patients who have had decreased sensation have gotten a lot of pleasure from that and been able to have a better intimate relationship with their partner or just to receive pleasure on their own. And so that's something definitely that can be tried as well. So there are a lot of things that can be done. But right now, if it's something that's been going on for years, it's probably unlikely that it's going to improve.
Yeah. All right, Ted, is there another question coming in?
Yes, we got a question from the ladies group.
Okay.
Has anyone had new worsening symptoms but no new or active lesions?
So that's a common thing that can happen. So it's very confusing because you think about the fact that why am I having new symptoms when I haven't had new damage on my MRI? I go to my neurologist and they tell me my MRI is stable, but I feel worse. So one of the things that we can see in MS that we've talked about a little bit tonight is progression, and that can be worsening of symptoms outside of a relapse. And so if you've noticed that you've had a decline in function over time, or you felt like your fatigue has worsened over time, or you've had increased numbness or neuropathic pain, that can be due to progression. And a lot of times that's due to atrophy or shrinkage of the brain or spinal cord that can happen naturally over time where there's been inflammation, where things can get worse. But I think most commonly it's due to other factors. So if somebody's experiencing the significant heat that I'm sure they have going on in Florida right now, and Erica can speak to that, or if somebody has a urinary tract infection, or they really just overdid it at work and really exerted themselves, or had a great day but walked a lot, and exerted themselves, those symptoms can come out and be really increased. And certainly if you have an infection or you have a wound of some sort, or really any kind of painful or noxious stimuli, that can increase current symptoms. And so that's something important to look for. That can make symptoms worse. But I would say if somebody has a brand new symptom, something that they never had before, particularly that came on in the form of a relapse, something over hours to days, that's very concerning that there could be new disease activity. And one of the things that I teach my neurology residents, so doctors in training to become MS care providers, is that even if the MRI doesn't show new disease activity, it really depends on how good the MRI is, because the MRI does have gaps in the imaging, and it could skip an area of the brain, and we could miss a new lesion. So if somebody's having new symptoms that they've never had before and it's consistent with a relapse and there's nothing else going on, that's a relapse. And we can't just say, well, there's nothing new on the MRI, so you must be making it up. So, it's really important to sort out what's going on. But I think that, the most common cause of symptoms being increased is really something else going on that's making that issue worse, like an infection or heat sensitivity or exhaustion. And then if that's not the case, we also want to look and see if we feel like there's been progression of the disease over time. But the good news is that if symptoms are increasing, we have the biggest joke in our clinic, which, again, neurologists are not funny, but we say that there's a pill for every ill. And if you've got a symptom, there's something that we can do to try to make it better. It's not that we can take it away or we can make it perfect, but there's something that we can try to do. So I think if you have something that's bothering you, bringing it up to your doctor and just asking what can be done and telling them this is really important to you can be really helpful in getting some help for that issue.
Yeah, I agree. Let's see if we can find another one coming in. Let's see. Ladies group has one. Do you take the flu shot every year? I have heard different responses from a handful of neuros I've seen, and we want to expand on that. We want to explain about all vaccines because we recently had a debate in one of our groups about the shingle shot as well. So what is your opinion on that, Dr. Nicholson, on the not only the flu shot but also other vaccines like the shingles vaccine?
Absolutely. So we can talk about that. And first of all, everybody calls me Dr. Nicholson, and they change my name all the time, but it's Dr. Nicholas.
Yes.
So
did I say
as far
Nicholson?
As
I'm sorry.
it's
We're
totally okay
today.
I respond to anything, and it's funny because I always get that, or people call me Dr. Nichols, and I say, as long as you say it nicely, I'll respond to anything.
That's right.
So,
or I could call you Dr. J from on Twitter.
Yeah,
I'm so
like
used
that.
to seeing you on Twitter. I'm used to seeing Dr. J on Twitter. I always, in my brain, I'm always going, Dr. J, Dr. J.
Yep, you can call me anything. So as long as it's not an obscenity. As far as flu vaccines, those have been proven to be incredibly safe in MS. And so those are very strongly recommended. They haven't been shown to increase risk of attack. And so it's really important. And really, regardless of disease-modifying therapy that somebody's on, it's recommended and it's safe. And the nice thing is that the shot flu vaccine is inactivated. So it would not cause somebody who's on something that potentially has suppressed their immune system any problems. The only concern is that if you're on a medication that may prevent your body from producing an immune response against that vaccine, you may just receive the vaccine but not actually develop immunity because your immune system is suppressed. So for instance, let's talk about one of our MS medicines called Lemtrada or alemtuzumab. If somebody's receiving that vaccine, our real goal is to try to give it 6 weeks before their next Lemtrada infusion. So if somebody's going to receive it in, October, we want to try to give it sort of at the end of August, right when that flu vaccine comes out, because then their immune system will be able to build up immunity before they actually develop some immune suppression from that medication. But regardless, even if you received it when you were on any medication, it would not cause you any harm. The only potential is that with certain medications, you may not build up immunity. With most of our medications, you would. One of the other medicines that I'd say would be concerning that you potentially would not build up immunity would be fingolimod or Gilenya. And that's because, your white blood cells are really sequestered in your lymph nodes. But I still think it's worth getting the shot and, trying to add that potential protection. But there are other vaccines that we are concerned could be harmful in people with MS. Mainly, those are vaccines that are live vaccines. So one of the most common things that I'm asked in clinic is whether or not somebody should get a shingles vaccine, because once we've had the chicken pox, which a lot of us have if we're, over the age of about 25, although they developed a vaccine for chicken pox that many younger people have received now, and they never had chicken pox. But if you've had chicken pox, the concern is that there is a risk for shingles at some point in time, and that's reactivation of the chicken pox that you had, and that could happen at any point in time and tends to increase in risk as we grow up, so as we get older. That vaccine's live, and there's a risk that can lead to increased risk of relapse or new lesions on MRI, and so we really don't recommend that vaccination. However, if people have had chicken pox earlier and they have the virus in their bodies already, and there's concern that they could have shingles and their disease has been pretty quiet, it's really a risk-benefit discussion, but I think you should always bring that up with your neurologist who's treating your MS to find out if they feel that's a really good benefit versus risk decision. There certainly are other vaccines that we've become concerned about. And, certainly if you're traveling to another area of the world, one of the vaccines that has raised concern has really been the yellow fever vaccine, particularly if people are traveling to Africa. And so, if you're going to Africa, whether or not you get the vaccine, it may be something that you consider getting it. But we think that it is probably not safe in people with MS and could certainly increase the risk of disease activity. And then also, any inactivated vaccines we think are very, very safe. So really, because there's so many vaccines out there, I think the most important thing is that no matter, what type of MS you have, no matter what medications you're on or not on, I think it's always good to check in with your neurologist or MS specialist to find out, hey, is this a good idea for me? Because there might be nuances based on what you've dealt with that they may not recommend it, or they may say, you know what, that's not a worry to me at all. But I definitely think that the vaccine, the flu vaccine, is very safe for everyone. The only important thing that I would note about that is that make sure you get the shot. There is a inhaled formulation available. That's a live vaccine. That's typically only offered to kiddos because, they obviously have more sensitivity to getting an injection. And so if that's offered to you, please ask for the shot because that's inactivated and the inhaled could be potentially harmful to you.
Now, if our children are offered the inhaled form at school, is that something that we should opt out of and have them have the injectable?
So it actually would be perfectly fine. So really for them, the fact that they're getting the inhaled, it means, their system is functioning normally. And so that would be completely okay. But you're not at increased risk to get the flu from them by getting the inhaled form. But it's absolutely a great idea that, everybody in your family that you're around, we would want them to get the flu vaccine and their normal vaccines because that'll help make you safer so that someone in your home isn't as likely to get the flu, which could affect you much more severely because you have MS.
No, thank you for clarifying that because I know a lot of moms have that concern. MS moms have that concern this time of year with school starting back, and a lot of schools have started offering that right in the school system. Another one I wanted to make a personal comment on was on the shingles vaccine, the Zostavax. I know that you made it very clear, how, risky it can be for us because it is a live vaccine and you really need to talk to your doctor about it. But many people might say, oh, well, then it's definitely out, and make that personal decision not even to speak to their doctor about it. But if you are at high risk for the shingles, I urge you to have that conversation with your physician, because my uncle is now going through a surgical consult to save his eyesight because of shingles. So it can be more serious if you haven't looked into shingles and what they are. It's more, it's more than just getting some things that hurt a little bit in a line on your tummy. It's very more expensive than that, and you need to look into it, consider it seriously, and talk to your doctor about it. So it's definitely a little more serious than some people might assume. All right, Ted, is there anything else coming in? Oh, you're welcome. Yeah, I just wanted to put that aside in there because it just happened in my family. So I know some people might not take it quite as serious as a decision as it should be.
We got something coming across on Twitter.
Okay. All right. What is that?
Does menopause or hysterectomy affect MS?
This piggybacks off of what you were talking about earlier. Now, specifically menopause or hysterectomy, how does that affect MS?
So interestingly, I would consider both pretty scenario. Now, if somebody had a hysterectomy but they didn't have their ovaries removed, that would be a different scenario as opposed to having just a hysterectomy with your ovaries intact, because you would still have the normal hormone levels if you hadn't yet gone through menopause. With menopause, we know that we have a significant drop in our estrogen and progesterone. And interestingly, there have been several studies looking at what women experience when they have MS and they go through menopause and afterwards. And we know from all of those studies that women with MS report more symptoms and often worsening of symptoms. And what we don't really know at this point is whether that's related to disease activity or if that's actually related to just progression of the disease. But I will say that many women report increased symptoms during that time, and I think that it probably is related to the alteration of, drop in the estrogen and progesterone. One of the tough things is that certainly when somebody's having issues with hot flashes and they already have MS, we know that heat sensitivity can be a big deal, and so hot flashes, even though in somebody that doesn't have MS can be really uncomfortable, they're incredibly uncomfortable for somebody with MS who then has increased symptoms. So, it can be a discussion with your neurologist and with your OBGYN. Sometimes they may consider using hormonal treatments during this time to help you tolerate that. We obviously also have to be very careful given the increased risk of breast cancer or endometrial cancer based on adding estrogen or progesterone supplements. So I think, it's an area of research that really hasn't been sorted out, and I think we need to learn a lot more, because we know that typically when we reach menopause, we're at an older age, so there is that factor of aging and progression in MS, but also with the hot flashes and the change in the hormone levels, that can greatly affect mood and fatigue and overall well-being. And so, my hope is that in the coming years we'll have more information on that.
Yeah, because the recent studies I've read, it just went back and forth. And the last one I read, they did, it was only 124 women, though, which, of course, affects the quality of the study. And they followed them over 10 years. And I was reading it because I'm 47, and I'm getting to that age. And they were measured by EDSS. And for the most part, menopause did not have a large effect on that. So, it's just so confusing. But from what we see, from our large groups online with tens of thousands every day, it does seem to have an effect, like you said. And I think it could be exactly what you said, hormone related. And speaking to that joke you made about neurologists not being funny, I think the MSers are. One of them said this week, is it okay if I go around and wear ice packs on my bra? Yeah, you know what? If you're that miserable, go right ahead. Stick them in your bra.
It is.
Whatever it takes to function. All right. Let's see. We have another one coming in. This is from our Info Hub group, which is our main group on Facebook. This one says, is uncontrollable cold limbs related to MS, no Raynaud's, no circulation problems? Because that would have been the first thing I would have went to, Raynaud's or poor circulation.
Exactly. So that's a really important question, and it actually can be related to MS. So, that's something that I was very surprised about when I was a medical student and I learned about that. But through the thoracic spinal cord, we actually have our autonomic nervous system, which regulates temperature and actually goes up through the upper portion of the spinal cord. And individuals who've had thoracic spinal cord lesions, high thoracic spinal cord lesions from MS, there can be a syndrome when you develop one limb that is cold, discolored. It can appear swollen, and most people will think that's a vascular issue, but it's actually not. It's actually a disruption of the autonomic nervous system. And so when that happens, it's definitely important to always make sure there's not a blood clot, there's not something else going on, but it is a very common reason directly due to MS that can occur. And people can also have lesions in an area of the brain which controls temperature regulation called the hypothalamus, and that sometimes can cause difficulty with temperature regulation. We see that more commonly in a childhood syndrome of inflammatory brain disease called ADEM, or acute demyelinating encephalomyelitis. But people with ADEM can go on to have MS as well. And so those would be the two reasons related to MS that we could see that.
Yeah, that's very interesting. When my left arm first started losing function, it looked, it was always white looking. There was no blood flow. It was ice cold. I had weird shape up at the top of it. And I was very suspicious that it might be, something to do with my spinal cord instead of, like brain progression. So I wasn't really sure. I asked my specialist, and they kept just, sloughing it off as progression. Oh, it's just another stage or event. And I thought, but is this something we could treat? I'm like, can we get this back? I want my mind to immediately go to something we can treat. Yeah, so that's interesting that you said that.
That's the tough thing. Yeah.
Yeah, that's the thing, because we always want to fix for it. We don't want to hear it's part of your disease course, your progression. We want to hear, okay, if it's a lesion, we can give you steroids. We want a treatment for it each time. We want to know that we can get it back.
That's the most important thing. And I think, if that's something that comes on, certainly treating a relapse, if that has happened newly, may help to improve that symptom. But the tough thing is if you've had it again for a year or years, unfortunately right now there's nothing that we have to repair that damage that was done in the thoracic spine. And so, we're waiting and hoping that we're going to have these remyelinating or restorative agents in time that potentially could help us improve.
Yeah, and I'm very hopeful with everything we're seeing. I know it's all, in the development stage, but we have to see the patient trials and everything. But I'm just hopeful that they're getting that far with the research and that there are new things, and we have that hope now and so many new things coming out. I think that we need to spread that hope and the joy of just how effective some of the new treatments are, and that we need, and all of the comprehensive care we're getting, like we're getting, at your MS Center and at the one I'm at, and that we can set up that same type of cooperation and comprehensive care, other places that don't have the resources, to necessarily have an MS center, but we can encourage more communication and comprehensive care, and patients becoming their own advocate, before these things get beyond treatment, or you miss out on an opportunity to make an improvement because you didn't know that there was something available, a therapy available, a follow-up available. to you when something comes up with your disease course. Okay, let's see if there's anything that's come in. We do have one from the ladies group. What is the best way to deal with chest spasticity when muscle relaxers don't seem to do the trick? Well, since that's your specialty, I'll let you take this one, Dr. Nicholas.
So the question mentioned was chest spasticity. And yes. I would say that if muscle relaxers aren't doing the trick, then one of the options would be botulinum toxin injections. So generally, Botox can be injected into any muscle, and so even the chest is entirely made up of muscles. And some of the most common muscles in the chest that can cause problems are actually our pectoralis muscles. We have two big ones, the pectoralis major and minor, and those can feel really tight, and they're very easily accessible for botulinum toxin injections. And that can help quite a bit and be a very significant benefit. I'd say if the oral muscle relaxers didn't work, that would be the first place that I would go. You know, we talked tonight about baclofen pumps, but generally the baclofen pumps work best for the legs rather than the upper body. They do have some effect on the upper body, but it can it's much less significant than what it is on the legs. In lower body. So that's why I would really consider the Botox injections for that.
Yeah, that's a great choice. At least there is a choice for that. Let's see if we can see another one coming in on social media. I see one in singles online. Let's see. How much has science advanced MS research, and how much is still unknown about MS? Well, we were just talking about that, actually. You know, we've made such great strides in understanding the process, the triggers in multiple sclerosis, the amazing research we've been talking about that's been released in just the past year on the mutated genes responsible for MS and other autoimmune diseases, which we very quickly went from like 115 up to 125 already being reported. But several of the environmental triggers have been identified, which we've even discussed those today, and, you know, they're currently related to that, you know, there's current studies on those trigger processes. They're trying to fully understand all the triggers and how to turn them off. And like the doctor was saying, remyelination therapies are underway. So they're studying Epstein-Barr, smoking, remyelination. But, you know, a lot of it's in the early stages. But I personally, just a personal comment, predict therapies that turn off triggers, remyelination, stem cell therapy treatments, more developed, it coming to us within the next 9 years. I mean, I'm very hopeful for that, maybe even sooner on some of them. But Dr. Nicholas, would you like to give your professional opinion on it?
Yeah, so I think that, you know, the very exciting thing has been obviously in MS, we have seen a rapid change in the knowledge about this disease, about the risk factors for this disease, and also about treatments for MS that have been incredibly, you know, significant in this field, you know, even in the past decade. So there have been great strides made, and I think that's very promising. Now, we have a lot to learn. We, despite studying this disease for well over 100 years, you know, about 20-some years now, we don't know what causes it. We know a lot about the risk factors. We know that there are still risk factors out there that we don't know because there are clearly people who don't have any of the risk factors who still develop this disease, who don't have any family history. And also, we want a cure. You know, we are not satisfied with the treatments that we have. I love the fact that we have all these new treatments, but we won't stop and we won't be happy until we find a cure. And you know, my hope is that we'll have that in my lifetime. I'm pretty young, so I've got a lot of years to live. I don't think that that's something that's coming soon, but I think that it is possible. And, you know, I think that, you know, there are so many people interested in this disease. I think one of the most exciting experiences that I've had is every year going to attend the annual ECTRIMS meeting or the European Congress on Treatment in MS. And that meeting, you know, when you go, if any of you have ever had the chance to attend, you see that there are thousands and thousands and thousands of individuals in this entire world studying this disease and working to find answers. And so I agree with you that I think within the next 5 to 10 years, we are going to have a significant difference in the treatments available, not only from a standpoint of just preventing progression, but potentially fixing damage that's already been done. There's been a lot of promise with the treatments that are being studied. And I think even when we develop a new treatment, every time we develop a new treatment that works in MS, we learn something new about why MS causes problems. And so each treatment has taught us more about why MS occurs and what we can do to help prevent it from becoming worse than, you know, all the other knowledge that we've gained in MS. And so I think this is still a field wide open for research. We have more questions than we have answers. But I think that there are really wonderful people working in this field and really wonderful patients who are asking these questions and pushing for what they want to help their lives. And so I think the future is really bright. And even though we've come out with a lot of great treatments, I think that 10 years from now, we'll kind of look back on where we are now. We'll think, oh my goodness, they didn't know all the things that we know now. And look how much different these treatments are than what we had back then.
That's true. It's a very hopeful time. A long way to go, but we have very hopeful times. Now, we're coming almost to the end of the show, but we have time for a really, really quick question. This one was actually a follow-up that was sent through to the chest spasticity question, and they said, but what kind of exercises would be best if we have leg spasticity and foot drop?
Okay. So in terms of leg spasticity or foot drop, there are, mainly stretching exercises. So it would really depend on which muscles are stiff. So certainly if the foot drop is due to weakness, purely weakness of that dorsiflexor of the foot, it's a muscle called the tibia anterior. There are strengthening exercises that could be done, but sometimes when somebody has spasticity, that's due to the opposite muscles, so the calf muscles, which are actually the gastrocnemius and soleus muscle, that can be overly stiff, and they can force that foot to be pushed down. And so it really matters that you'd be evaluated by a neuro and your neurologist to determine what the problem is, if it's a pure weakness of the dorsiflexors of the foot, or if it's a combination of that along with stiffness in the plantar flexors of the foot, so the gastroc and soleus, because those may be muscles that they say, well, these are really causing a problem, and so if we stretch these more or we address that stiffness in those muscles, then your foot drop might not be as bad. And so I think it's really individualized based on the individual person, and you need a really good exam to determine exactly where the problems are. But I have no doubt that meeting with a specialized neuro PT and your doctor could really help to determine what's a good plan for you.
Yeah, that's a good information for them, yeah. And definitely that follow-up for the patient who sent in that question. Now, I wanted to thank you so much, Dr. Nicholas, for joining us tonight. You're welcome back anytime at MS&Me Radio, because I think we've really shared a lot of vital information tonight, maybe cleared up a lot of things for everyone and encouraged them to have that open communication with their doctor and care teams, which is so important. You're just a pleasure, and as I said, you're welcome back here anytime. So we thank you for joining us. And Ted, thank you for joining, too, and helping out with the questions tonight and controlling the board and keeping everything going. I always appreciate you here in the studio. Really appreciate that. Ted is actually our station manager. Oh, you're so welcome. He's actually our station manager for our new network, MS&Me Media Network. We have a 24/7, it's 7 days a week, radio network for you guys now. So anytime that you need MS information, patient support, just need to get on there and listen from other clinicians and patients and everyone from around the MS community. It's global, So you'll hear people from the UK and Australia and everywhere, all Canada, all joining in to make this a 24/7 network for you, giving you great information. So go ahead and go to our website, www.msmemedia.com, if you want to keep up on the latest. You want to find the schedule. You want to see what the new hosts we have coming on. Our big premiere is going to be on August 13th. So Ted is busy working, getting the big premiere going. And we just want everyone to be able to have this resource. And it's a pleasure of ours to offer that to all of you, and hope that everyone will join in, and whoever else wants to join in on the platform and share that information, you're definitely welcome. Just send us a message, and we will definitely get in contact with you. So have a wonderful evening, everyone. Our next show will be on the new network. It is moving to Sundays, 3 p.m. So that's 3 p.m. Eastern Standard Time on Sundays from now on for MS&Me Radio. Thank you guys so much, and have a wonderful evening. Thank you guys for being on here tonight. Good night. Have a wonderful night.
You too.
Thank you. Bye.
Bye.